Make sure it turns green. There you go.
Good evening, everyone. Thank you so very much for your patience. We really, really appreciate it. It's never easy to host a lecture with multiple people in the room and then people on the web asking questions and so forth from the IT standpoint. So really appreciate your patience. Just a few housekeeping reminders before we begin. Please turn off your cell phones so that we don't get interrupted during Dr. Lexell's excellent lecture. For anyone who needs a restroom, it's right down the hallway this direction. During the question and answer period, we ask that people please wait for the mic. So if you have a question, raise your hand. We'll bring you the microphone so that the people who are watching the webcast can also hear you. If there's anything you need during the lecture, we have several volunteers around the room, so please just raise your hand. We're happy to assist you with more food, water, whatever it might be. And finally, at the end of the lecture, please don't forget to fill out a survey before you leave. This is incredibly important because we need that feedback on your experiences, your thoughts, and also ideas for topics into the future. So we'll begin in just a moment when we get the green light. Jenny, everything good? Okay. So again, thank you very much for joining us for the Spalding New England Regional Spinal Cord Injury Center Knowledge and Motion Lecture Series. I'd like to welcome everyone officially and also thank all of our staff who are here working so hard to make this happen and happen in a smooth way. I'd also like to thank two special guests, Kristen McCosh, the Commissioner on Disability for the City of Boston. Kristen, raise your hand. You're an important person. And also, we want to thank our the Director of the Spinal Cord Injury Model System, Dr. Ross LaFont, for joining us this evening. Thank you, Ross. And then, thank you. I'd also like to welcome our webcast attendees from 27 states across the United States, as well as countries such as Canada, India, and New Zealand. So a quick overview of our speaker. We're very, very fortunate this evening to be joined by one of the preeminent physiatrists globally on the topic of spinal cord injury. He has graced us with his presence over the week in exchange with regards to information sharing on multiple topics to include spinal cord injury medicine. Dr. Jan Lexell, here to my right, is a professor in the Department of Neuroscience at Uppsala University in Sweden. He's also the head of the Rehabilitation Medicine Research Group and is board certified in both neurology and physical medicine and rehabilitation. Jan has done a tremendous amount of work looking at spinal cord injury over the course of his career and also uniquely done some of the most important research in trying to understand the impact of spinal cord injury in individuals who have been injured for quite some time and are moving through life and aging with spinal cord injury, and that's what we'll be learning about this evening. I've also had the pleasure of getting to know Dr. Lexell as a colleague and friend, as he also serves with us on the medical committee for the International Paralympic Committee, really thinking about the impact of physical activity and exercise on people with many types of disabilities, including spinal cord injury. So he's here to join us this evening to talk about aging with spinal cord injury, focus on function, physical activity, well-being. I'd like to welcome him to the podium. Thank you.
Thank you very much, Dr. Blau, for that kind introduction. I'm very pleased to be here and very grateful for the invitation to speak. It's been a tremendously interesting week, seeing what you do here at Spalding, talking to people, and I've been accompanied with my son, who's on a work orientation period from school. Just to see what it means being a traveling scientist and clinician. Getting through those dreadful weather we had on Monday, for example, during the Boston Marathon, and all the receptions and everything else, not let alone a lecture like this. I'm in transit from Lund University to Uppsala University, where I started in January this year. I'm trained in neurology and rehabilitation medicine, as we say in Europe, and my entire career has been devoted to research, teaching, and clinical work in the field of neurorehabilitation. But as you also heard, I have, through my lifelong engagement and interest in physical activity and sports, also been fortunate enough to be involved in Paralympic sports over the past 10 years. Uppsala University, which is located just north of Stockholm, as you can see on this map. It's actually the first university founded in Sweden well over 500 years ago. Someone reminded me that, well, isn't that even before America was discovered? Whoever discovered it? Yes, I said. So it's a pretty old one. Talking about aging, there are fortunately good things happening with aging in the university world. We have around 50,000 registered students and 2,500 PhD students. The history, the culture, and the heritage is something I'm going to explore, and it dates back several hundred years, similar to what you see here at Harvard, and that makes academic life both interesting and somewhat challenging in some ways. What I'm going to talk about tonight is work that we initiated in my former university, Lund University, the Swedish Aging with Spinal Cord Injury Study, or SASCIS, as we have the acronym for it. It's an ongoing longitudinal study initiated already 2011. And if you go back and precede, before that, my interest in aging goes back to around mid-80s, when much of my work related to aging and muscle was done. And aging has been sort of an issue, an interest, a variable that has followed me over the years. It's one of those areas where you can actually benefit quite a lot from the research yourself. And looking out here, there are a number of you who may have some interest in the area of aging. We're a small group. There's 2 physicians, rehab physicians working with me. Dr. Sofie Jørgensen graduated on the thesis work related to this project last year. We're also working with Professor Martin Guinness in Canada, who's an exercise psychologist and relates very much to physical activity. That is a key interest here. And there are also 2 occupational therapists involved in the work. Spinal cord injury in Sweden, we're a small country. We're only 10 million inhabitants. So we see many, not as many spinal cord injuries in total as you would see over here. We're about 300 per year. The interesting thing is the panorama, the demographics are very similar to what you would see over here, with about 63% men, and nowadays 67% 45 years or older. And this is an interesting thing happening across the world, and even in the US, that you see more and more older people being injured. When I started over 20 years ago, the average age was around 30. You don't see the same panorama, the same kind of demographics, injury characteristics anymore. So all in all, there are about 6,000 people living with a traumatic spinal cord injury in Sweden. We have less accurate figures when it comes to non-traumatic injuries. What is specific for our country is that we're a nationalized health service, which entitles everyone to, with a spinal cord injury, to a lifelong follow-up at a spinal cord injury clinic as long as they live. So this is a national policy. And with the national registries we have, we can trace people wherever they move within the country. You all know about the effects of the spinal cord injury. There are a number of things happening, not least the paralysis, but also bowel and bladder dysfunction. There's pain and spasticity, which are the 2 most commonly reported secondary health conditions following a spinal cord injury. But there are also sensory impairments, sexual impairments, and for those with a high level injury, disorders of the respiratory system, and an effect on regulation of blood pressure, heart rate, and body temperature. This altogether leads to activity limitations and restrictions in participations, which we believe and know ultimately affect a person's whole life situation and to some extent may reduce it. What's interesting, and this is a trend all across the world, when we teach about spinal cord injury rehab, we say that the start was really right after the Second World War, where 80% died within 2 weeks. Nowadays, people with a lower injury in the lumbar spine have similar, there's no premature aging to that. However, older people with a higher level injury still has a shorter life expectancy. What we've seen through the advances in healthcare and rehab is a growing number of older people with spinal cord injury. We know that there is an accelerated aging and also a vulnerability to age-related changes related in these people. And this together leads to an increased disability and reduced quality of life. This is what we see in the clinical context. However, what's interesting is that there is still limited knowledge of aging with long-term spinal cord injury. So there is clearly a need for more research in the field. Therefore, aging and spinal cord injury is among the top 10 priorities in spinal cord injury research and has emerged as one of the many topics that we see in spinal cord injury conferences. When we started this about 10 years ago, there were no comprehensive studies of aging with spinal cord injury in Northern Europe. One may say that does it matter? Couldn't you extrapolate data from one culture to the other? Well, we cannot do that. We need to see how specific country-specific healthcare systems handle these things and how that affects longevity in spinal cord injured people. So basically, there is no consensus regarding the long-term management, and we still need to come up with more and more knowledge on how we can support active and healthy aging after a spinal cord injury. With that in mind, we started the Swedish Aging with Spinal Cord Injury study, the SASCIS, about 10 years ago, which is a descriptive population-based longitudinal study where people and the inclusion criteria are that you're 50 years old and older and have at least lived with your spinal cord injury for 10 years. What we tried to do at the time when we started was to set up a really comprehensive list of assessments based on what we call the International Classification of Functional Disability and Health. That means that we're covering not only the medical part, but anything from the sociodemographics, injury characteristics, across secondary health conditions, activity limitations, over to personal factors, life situations, what happens in the environment and how that impacts on your life, and also lifestyle-related factors. And we're really just sort of scraping on the surface of all the data that we have collected so far. And I'm going to give you a short glimpse of some of the data. The overall aim is to increase our knowledge of people aging with long-term spinal cord injury and thereby come up with follow-up programs that can be tailored specifically to this segment of the spinal cord injury population. Hopefully, this can lead to specific lifestyle interventions and thereby impact on the healthy aging in people with spinal cord injury. I should also say that all the references you see in the back are available, freely available. You can either download them from the journals, or if you search on my name on ResearchGate, they're all available around there, or contact me directly. Now, the population that we're studying are 123 participants. They come from a cohort of close to 700 persons that we had in our own records, dating back around 30 years in Sweden. And as you can see, the demographics in terms of gender and trauma versus non-traumatic injuries, about what you see normally today. The injury levels covered anything from very high level down to low level. And also in terms of the injury severity, we have anything from complete injuries all across to those who are mildly injured. The mean age for our cohort is 63, and people have lived for anything from 10 up to 56 years. And you can see the demographics in terms of family life, assistance, and employment. A third still being employed. Now, we divided them into 3 groups for statistical reasons. So we're looking at those who have a tetraplegia and are wheelchair users, those who are paraplegic and are wheelchair users, and the rest, which includes anything from those with a milder injury to those who are actually recovered and are walking. This is just a list to show you the number of assessment tools that we have. On the left side, you have the generic ones, which covers a number of variables, for example, depression, life satisfaction, something we call sense of coherence. And on the right, spinal cord injury specific. I will come back to some of these results because the results that we have are based on using these assessments tools. First of all, what does it look like in terms of the secondary health conditions? That is sort of the remaining symptoms, if you put it that way, from the spinal cord injury. Well, as you can see, less than half have reported bladder-related problems and bowel-related problems, such as incontinence, urgency, and obstipation. 44% spasticity, which altogether are lower than you would see from other studies in the literature. However, a vast majority reported pain, and 2/3 moderate to severe pain. What was interesting was that there was no association with the level and severity of injury, which is what you normally see in these populations. But we found that the moderate and severe pain was associated with unemployment. So clearly, how you take on your life does seem to have an impact on at least one of these secondary health conditions, namely pain. When it comes to activity limitation, meaning what you can do in regular life, we found that overall there was a moderate independence in daily activities. So not too bad, not too good. The level and the severity of injury was the absolute strongest explanatory factor. So if you had a high level injury, then you were less independent. If you had a lower level and a less severe injury, you were more independent. We found very little in terms of other factors except for spasticity, which then, as I will come back to in the concluding remarks, is an important aspect to actually look for because that impacts on your activity and what you can perform in daily life. We were interested in aspects of sort of personal life, mental health, and all these sort of, softer measures of how the life situation looks like. So we looked into depressive symptoms, and we're using a scale called geriatric depression scale. This is a very simple scale that's been used all across a number of conditions. We found that about 1/3 had clinically significant depressive symptoms, but only 5% probable depression. And that is the same or even lower than you would see in the general population. Again, the actual sociodemographics and injury characteristics have very little association with depression. When we look closer into other aspects of a person's life, we can see more interesting associations. The strongest one with depression was something called sense of coherence. Sense of coherence is something that was developed about 40 years ago and explains why people find life worthy of living. So as the definition is that people's orientation towards life determines their ability to preserve good health. So the more positively you look at your life, the better you are at handling external strains. And not surprisingly, we found that a higher sense of coherence was related to fewer depressive symptoms. And this is really the strongest association. which then implies that the counseling, the support that you can get and actually live a good life does affect your mental health. Coping and coping strategies is along the similar line, and we find that higher acceptance was also related to fewer symptoms. With regard to the more sort of objective measures, we found that neuropathic pain was also related to more depressive symptoms. So again, pain comes in as one factor that could, if possible, when treated, be relevant for mental health. But also, interestingly enough, we found that those who were more physically active had also fewer depressive symptoms. This leads on to the area where we worked quite a lot looking into physical activity, and we look into the aspect of what we call leisure time physical activity. And LTPA are those activities that you perform during your free time, and not those included in sort of daily life. So these are what you do when you go training, when you go exercising, and so on. Up to when we published our study a year ago, there were no studies whatsoever about older people with spinal cord injury and their participation in leisure time physical activity. We use an instrument called Physical Activity Recall Assessment for people with spinal cord injury, or PARI-SCI, which is developed in Canada. And the Canadians have done a lot of work on physical activity and spinal cord injury. With that, which is an interview-based instrument, very valid, we can then calculate or determine the amount, intensity, and also the type of leisure time physical activity. What we found is a little bit daunting. These people report overall a median of only 50 minutes a day of physical activity, leisure time physical activity. And those who, when we look into it, that's moderate to heavy leisure time physical activity. And the important point here is that the moderate to heavy is what you need to reach those health benefits that physical activity gives you. They're only 5 minutes a day, and 1/3 of our participants did no leisure time physical activity whatsoever. This graph shows the distribution of physical activity and the importance of those with moderate to heavy. The important part is if you look towards the right end of the scale, there are actually people who did about 2 hours of physical activity a day. So it is possible to maintain an active lifestyle. And this is something we need to carry on focusing on, because we will see then there are also some other health benefits, not only related to mental health when it comes to physical activity. What we found when we look at the data on the leisure time physical activity and the associations, there was no association with age, time since injury, or level and severity of injury. These are what we call non-modifiable factors, and they together explain only 13%. Someone will say, well, that's not very good. Well, I would say this is very good, because you can't change the time since injury, you can't change age or the level and severity of injury. So there's a whole array of factors that explain why and why not you're physically active. What we found was that women were less physically active, the wheelchair user, perhaps not surprisingly, and being employed. Work is good for you, and you will see that work is one of the strongest factors for maintaining life satisfaction, but it does impact on how much physical activity you can perform. So really we need to search for the modifiable factors that could explain participation in leisure time physical activity among this group. And this is an area where our research will take us over the next few years. This also gives me a chance to present the spinal cord injury and exercise guidelines that were published just about 2 weeks ago in Spinal Cord, freely available, open access, so you can access them. These are new evidence-based scientific guidelines that describe the type and the minimum dose to improve fitness and cardiometabolic health in adults with spinal cord injury. It's worth looking into it. They say that at least 20 minutes of moderate to vigorous intensity, aerobic exercise twice a week, and 3 sets of strength training is enough to achieve, that is the minimum to achieve health benefits. However, the more, the better. But what's important here is that these data are based solely or almost exclusively on studies where the participants are only up to 65 years of age. So we have no evidence, no data whatsoever about older people. And this is really a lack of knowledge in the literature. And hopefully we will come up with some of that over the next years. Life satisfaction, finally, in terms of these variables that we looked at. Life satisfaction is an interesting variable. It relates to someone's evaluation of our current life situation and whether we have reached our goals in life or not. The more we feel that we've reached them, the better our life situation. What we find is that among these 123 people, they have a life satisfaction, a rate that life satisfaction, I should say, that is similar to able-bodied people. A third were satisfied or even highly satisfied, and only 5% were dissatisfied. We did not find an association with, let's say, depression or depressive symptoms, nor with age, gender, or time since injury or pain, which is a little bit interesting. However, what we did find was a very strong relationship with being in a partnership and being employed. So the two things that seems to matter whether you're happy with your life is if you have someone to live with, a partner or someone around you, and if you feel that you have a meaningful life in terms of often being productive, but it may not necessarily be there. A weak association with voluntary bladder function, but really very little else. So again, if we can prescribe a partner or find work, that will actually impact quite a lot on life satisfaction. However, if you remember, being employed meant that you did less physical activity. So there's always this sort of two-edged sword. We also recently looked into cardiovascular risk factors. And the reason is that cardiovascular disease is the prime disease that leads to premature morbidity and mortality. You die sooner and you get more disease if you have a cardiovascular disease. And still, even if we live in a country with socialized welfare, health care, people have access to healthcare, medication, and so on, we still found that more than half had a high blood pressure at the time of assessment, still being treated. 93% were overweight, 15% had a diabetic fasting glucose, and 75% dyslipidemia. So that's too high fat levels. Now, the importance of that is still not quite known. And whether you have all these risk factors or not cannot be entirely related to life expectancy and cardiovascular disease. But it is clear that it does play an important role. And on average, these people had about 3 risk factors. Again, we found very little association with sociodemographics and injury characteristics. So there are other factors that are important for the amount of cardiovascular risk factors you have. One of them being actually physical activity. And what we found was that although the association was very strong, that those who were moderately to heavy active doing moderate to heavy leisure time physical activity had a lower BMI, body mass index, and a lower waist circumference. These are the 2 measurable cardiovascular risk factors. So basically, you are less obese if you do physical activity. However, no other associations between physical activity and cardiovascular risk factors. This is a little bit discouraging because we all believe that doing physical activity is important for you in terms of cardiovascular health. But we apparently still have to know more about that in the older population. To look further into this is just part of the large study that we just about launched. And we're now going back from sort of the very broad aspects of life, life satisfaction, environment, and so on, and going down into the medical part, the medical, cellular, and morphological part. And this part of the study, which we call the Swedish Spinal Cord Injury Study on Cardiopulmonary and Autonomic Impairment, was launched just recently. This is a cross-sectional study of the population that we have that aims to characterize the cardiopulmonary and autonomic health status in those who have a severe and high-level spinal cord injury. With this, we hope to elucidate health consequences on the heart and lungs specific to these people by comparing them to matched controls. This is part of a very, very large study that is ongoing in Sweden right now. With that, we hope to come up with preventive strategies and thereby reduce the risk of cardiovascular and pulmonary disorders in these people. We collected the data, we're about to start analyzing, and it's going to be quite interesting to see. This graph, I'm not going to go into any details, but it shows the number of quite detailed examinations. Some of them I didn't even know on myself that you were able to do, where you're doing very, very detailed examinations of the cardiovascular system, pulmonary system, body composition, etc. So coming towards the end, let me conclude and also relate to the clinical implications from these data that we have so far. Interestingly, when I meet patients, people with spinal cord injury in my outpatient clinic, and I do see the follow-up, it's not always that you find that your research links very closely to what you see in daily life. And sometimes some people say, well, we already know this, why do you need to do the research? But by linking them together, we can then convey the message very clear to people about whether it is good or bad being old with a spinal cord injury. And I can say that a lot of what we found in this research is actually coming through true when I meet the persons in my clinic. And we see that there is a lower occurrence of bowel-related and bladder-related problems and spasticity than in previous studies, and this is encouraging. However, pain is very common. Although it is not associated with physical independence, leisure time, physical activity, or life satisfaction, it is associated with mental health and also employment. So really, clearly, there is a need to evaluate pain and manage pain during the clinical follow-ups. As you all know, pain is very difficult to manage in someone with a spinal cord injury. What we see is also that level and severity of injury and spasticity are important for the ability to perform daily activities. Now, you can't change the level and severity of injury, but with that, we know that those two factors are the strongest, and you don't need to look for anything else in terms of changing the course of what you do in your daily activities. We found a low occurrence of probable depression. That is very reassuring, and that in itself is also related to things like psychological resources, pain management, and leisure time physical activity. So in the clinic, you need to focus on that, and I would say specifically the psychological resources. By strengthening them through counseling and so on, you will see a number of positive factors occurring in someone's life. As many do not reach the amount and intensity of leisure time physical activity to achieve the fitness benefits, that is the moderate to heavy intensity, we need to be more alert to how much leisure time physical activity someone is doing, assess and encourage participation in that. And yesterday, when as part of my visit here, I was went following part of the disability and physical activity sports program here, and was impressed by the variety of activities and opportunities that Spalding provide to people. And I believe strongly that this is one way that we can improve life and also support healthy aging in older people by getting them more active. What comes with activity, and this is an area where it's so little studied, is also not only the health benefits in terms of, let's say, cardiovascular system or other aspects, but also the social component. And we've seen that in so many other studies looking into in the past in my research group, that the social environment, meaning what people you have around you, plays a very, very important role in how people perceive their life. And I believe that if you get people involved in physical activity, you meet with others, and that in itself has a strong impact on the entire life situation. So really the importance of the social interaction and having meaningful daily activities, where physical activity and sports can be one, does lead to a much better satisfying life situation. Now, the high occurrence of cardiovascular risk factors, that is something we also need to focus on, and the regular medical assessments and interventions are warranted. We know very little in this segment to what extent this is actually going to lead to a better life. And we need more studies in this area. And we also need to see, which is an interesting part, whether physical activity does lead to a better cardiovascular health. So finally, these are some of the data that we come up with, and what we are doing is constantly trying to implement the data and the results and the conclusions into our clinical practice. We're also going to continue our international comparisons because, as I said early on, the data we have from a very small segment in just one country needs to be compared with the rest of the world, so that you see if other aspects in the environment, the healthcare system, the society is also an important aspect of aging with spinal cord injury. What we're just completing now is the first longitudinal follow-up on these people, somewhere around 6.5 years after the first assessment. And with that, we can truly assess the effects of aging in spinal cord injured people. What we've seen so far are only a cross-sectional study, a description here and now. But with another follow-up period, so 2 assessments, we can see if there are changes over time. But we're also including qualitative studies, interviews, so that we can get more information about how a person perceives his or her aging process, and also looking into the barriers and facilitators for leisure-time physical activity participation, together with other aspects of that I mentioned earlier on. So hopefully in a few years' time, I might be able to come back and tell you more about what we found in this ongoing longitudinal study. With that, I thank you for your attention.
Thank you, Dr. I would like to now move into the time of the evening where we can ask some questions. There'll be some people with microphones, and you can raise your hand or indicate, and we've got someone right here.
I have 2 comments. One, I'm wondering if the lower incidence you're seeing for bladder and so forth problems is that you're looking mostly at people who have very long time injury things, so the combination of their body getting used to it and learning how to cope with it. So, gee, I don't miss standing up to be as much as I used to because it's been so long since I've been able to. And the other question is, have you done any looking at the impacts of balance related activities among populations, and that we don't do any like balance type stuff as people do when walking around.
On the first question, that's interesting. We don't know why why these people report less bowel and bladder related problems compared to other studies. It could be, and I have a suspicion that they tend to decrease with older age, but we don't know why. And that's something that would be worth looking into. And in particular, now that we will have data from a second follow-up to see whether they actually continue to decrease. No, we have not looked into balance. That is an area we don't have the equipment to do that, but it will be interesting for people who are walkers or partially walking or standing up. Yes.
Okay, thank you.
Any other questions in the audience?
So, Doug, so this might be a naive question, but how are you actually defining injury? Are we talking about trauma, physical trauma to a previously neurotypical spine?
Yes, the question was how we define trauma. These are both, I should say that early on, these are both traumatic and non-traumatic spinal cord injuries. So, and about 2/3 were traumatic, and a third were non-traumatic. So these are vascular incidents, for example, inflammatory. No, we don't include multiple sclerosis and those kind of things, but sudden impact on the spinal cord, not degenerative reasons for spinal cord injuries. No degeneratives.
We got a few questions over here.
Which do you think is more important for the long-term recovery of spinal cord injury? The social or the physical activity?
Good question. I think both are important. I don't think I can sort of value them one or the other, but if I should, I think the social environment is more important than actually physical activity. So the people you have around you daily mean more than how much physical activity you do. And that I extrapolate from all the other research that we've done, that we see that the social environment and relationships are important for all the other traumatic brain injury, Parkinson's disease, MS, and so on and so on. So I believe that if you're satisfied with that and you feel that you can do meaningful activities, that is important for maintaining a good life.
Okay, thank you.
There are a few webcast questions.
Hi, we have two webcast questions. How are people with SCI able to lose weight, especially around their waistline? Was it exercise primarily, diet primarily, or a combination? And how many minutes of exercise a day is needed to lose weight?
Ooh, that's a tricky question. We don't know. I mean, this is the study we've done is looking at the associations between leisure time physical activity and body mass index and waist circumference. So we don't know whether it's a combination of physical activity, diet, and so on. We really need more studies. The guidelines, the exercise guidelines that I presented did in fact find that around 30 minutes 3 times a week was effective in influencing your body composition. So we're talking about 30 minutes of moderate to intensive activity, which is very similar to the general recommendations from World Health Organization about physical activity. So it's not much.
Is there any sort of exercise that is effective for higher level injuries? Any examination of FES?
In the guidelines, we did not look into FES. There are some indications that it may affect body mass, it may affect bowel and so on. In terms of the activities, any activity that you can perform when you're a higher level spinal cord injured person is effective. It's the amount and the intensity that counts. So that's why it's important to meet people like, for example, people here at Spalding or an SCI clinic that could guide you to the activities that you can perform regularly in a safe way, and thereby over a longer period maintain your health.
Last one. Did he study the effective hours of sleep per night and weight management?
Again, that's a good question. I'm a strong believer that sleep does have an impact on your health. No, we did not study that.
I know that Caitlin had a question. Okay, so if we can move the microphone back over to Caitlin here. Great. Thank you for the webcast questions. We appreciate it.
Hi. I was injured 27 years ago, and at the time they told me and other patients as well that our spinal cord injuries didn't affect our life expectancy, but I feel like one of your slides contradicted that a little bit, or does it just depend on the level of injury?
Just to repeat the question, does your time since injury, does your spinal injury itself affect your life expectancy?
It's the level of injury has some influence. Very high level, C1, C2, has a shortened life expectancy. But when you're down to lower thoracic or even lumbar level, there is very little effect on your life expectancy nowadays, what we see.
What about higher thoracic?
Yeah, it's a sort of a gradient to some extent. So yes, there is an effect. And again, these are sort of average data for a whole group, but there is an effect. So the less injured and the lower level, the better. The higher the injury, the more severe, that can influence your life expectancy. But again, these are within sort of ranges of 5, 10, 15 years. So if you take across the whole span, there is a relationship and association between severity and level and life expectancy.
Hi. At one point you talked about lower occurrence of bowel-related and bladder-related problems and spasticity than previous studies, and I didn't know what that was relating to. Lower than what and why?
Well,
so I'm just going to repeat that question.
Yes.
At one point we referred to lower bowel and bladder problems and spasticity. I'm trying to understand where that comes into play.
What we found is that fewer people report bladder and bowel related problems and spasticity compared to other studies.
Fewer of the people in the study.
Fewer of the people in our
The older people. Okay.
Well, there are very, very few studies similar to us. So this is reported to this is compared to studies of younger people who have lived less, say, let's 5 to 10 years after an injury. And that relates to the first question, whether there is actually a reduction in problems related to bowel and bladder when you grow older. We don't know that yet, but there is a tendency to seeing not more problems, but actually less problems when you grow older.
That seems really counterintuitive, but glad to hear it.
It does, but that's the fact.
And another term you used was probable depression, which I don't understand that term.
Well, depression is a clinical, the question was what probable depression means. This is related to the assessment where you answer a number of questions, in this fact 15 of them. And if you answer at least 6 of them in a way, it would indicate that you might have a depression. However, it's not a yes or no assessment like when you do blood sugar, for example. So this would indicate that you might have a depression. But it's a clinical diagnosis, and it helps the clinician to decide whether the person actually has a depression. So depressive symptoms is one thing, and probable depression is where it's likely that you have, because you report very many of these questions in a way that would indicate that you may be depressed. But it's a clinical decision, so it's not that if you score X number on this scale that you get a prescription for a medication.
I saw their hands. And then we need to go back to the webcast in a minute. Okay, so we'll take 2 more questions here, and then we'll go back to the webcasters.
Were some of those depressive symptoms physical symptoms that might have been related to the injury itself? Is that why it may not have been considered depression itself? Depression?
The question is whether some of the depressive symptoms that are being used to assess probable depression may be related to the physical symptoms of having some injury.
That's a good point, and this particular assessment tool takes that into account, whereas others report, for example, pain. Pain is, if you report pain, that is an indication of a depressive symptom, and there are others related to spinal cord injury, but that's taken into account in this scale. Otherwise, we would over-report people with depressive symptoms or probable depression, because many of them have pain.
We have another question right here. Raise your hand. I know there was another one. Great. I'm repeating for the webcasters because this microphone is working for them, so just so you're aware of that.
So I was wondering if you would mind kind of giving some examples of what the regular follow-up entails in Sweden, and if you've observed any differences in the care that's kind of standard there versus what you've seen in your visit here.
I repeat the question. The question was the type of follow-ups that we do in Sweden, and whether that is different from the type of follow-ups I've seen here. I'm not entirely familiar with the follow-up system here. The follow-up system we have is that early on after the injury, we have very regular visits back to an SCI clinic, and that is every 1st, 2nd, 3rd, 5th year. And then it sort of it gets longer and longer between the follow-ups. But we individualize them very much. So if someone is growing older, we see more problems coming about, we can then schedule another follow-up very early on from the first one. If a person, let's say, is everything is working very well, no secondary health conditions to account for, we can sort of schedule it for between 5 years between the follow-ups. In between, if necessary, they can go to the general practitioner for let's say blood tests and so on. So the thing is that the follow-up system we see is an individualized one, depending on the need. I don't think it differs that much. It differs perhaps a little bit between different parts of the United States and sort of the insurance coverage and so on. But generally, this is something that's been worked out worldwide, the need for follow-ups early on and later on in life.
Thank you. We have some webcast questions.
I do have another webcast question. Did you see a difference in the physical health for people living in rural or urban centers?
Good question. Yes, we looked at that. We did not see a difference whether you lived in a city or in a rural area. There was no association between secondary health conditions, activity limitations, and so on. So we had that factor, the living where you lived, as one variable going through all the different studies. Except when it came to physical activity, it didn't come out significant. So we cannot say for sure that it did relate to it. But there seemed to be maybe a tendency that people living in a city were more active than those living in a rural area. But it's not significant, so we cannot say that for sure.
And other question?
really quickly, the further north you got in Sweden, like over the Arctic Circle, did that impact the results at all?
The further north you get in
Yes.
Sweden, does that impact the results?
That's an interesting question. I cannot answer that because the data were collected in people living mainly in the south of Sweden. From my experience, is that could perhaps, depending on how far you live out of the healthcare system, but we don't really know that.
So that might be interesting to study the Arctic Circle.
Oh, yes, definitely. The question was whether I can agree. Yes, it's interesting to see how the environment and the living condition does impact your health.
Do we have another question? Okay, great. Go right ahead, so you can get the mic to work.
Can you talk a little bit about accessibility differences and accessibility in Sweden versus the United States? Because certainly that can play a role.
The question was about accessibility and whether that plays a role here. We have looked at accessibility in terms of housing and how that relates to a person's perception of their participation in social activities. And we do see that if you report many problems in terms of your housing and accessibility, that impacts on your participation. And clearly you would then believe that it does may impact also on other aspects of life. Now, in terms of accessibility, we have a regulation that entitles someone with a spinal cord injury to housing adaptations free of charge, depending on the need you have, which is then related to the level and severity of your injury. We have other sort of regulations that support you in terms of transport, in terms of personal assistance and so on, which is clearly different from what you would see over here. This is a big issue now because the cost for that is rising. So we're facing the same problems as you do all around the world when it comes to a population of older people in need of this to live a full life. But it is a difference, and we have so far have had a very generous system, I would say.
Other questions? We have one here, and then we have a webcast questions.
Okay. I'm not very good at this. I can use a cell phone. Thank you. This was extremely interesting. I'm so glad you did the study. And one of the things, though, that I just wanted to mention is several years ago, I went over to Sweden for a study on how you provided personal care assistance. You provided a much more complex system than we can here because of money. And so it does make a huge difference in terms of how somebody can function. It also made a huge difference in terms of somebody returning to the community. But one of the other things that made a difference, and certainly is related to life satisfaction in terms of being able to get the help that you need, but I've also found that families make a huge difference, both in terms of the personal care assistance that people are able to get, and then transportation is the other big factor that many locations in this country are not as available. And so therefore, when people can't even get housing that's accessible, get out of their houses that's accessible, get some place where it's accessible, that it's really, and then if anything, we're seeing those services being reduced because of costs, just as you were mentioning, the costs. So first of all, I hope Sweden's able to maintain as much as possible for the people with spinal cord injuries so that they're able to get out and do things, because I think there is a strong relationship. But my question would be how much you looked at family participation, and did you look at people that were not able to live in the community, but were forced into, well, here they would be called nursing homes, but I know that they try not to call them nursing homes in Sweden. Most people in Sweden were like 90 and above, I think, but that
whether or not you looked at the people where there was a long-term study done of people that didn't have some of those benefits at the beginning to help them adjust, because it's going to make a huge difference also in their assessment of their quality of life. So, comment, question, did you look at families, I guess?
Should we repeat the question? Yeah. The question was about sort of healthcare and social support that you can receive if you have a disability. The system we have had in place for many decades, the main thing is to allow people and enable people with a disability to live in their own houses and homes as long as possible. And all these 123 people were interviewed in their own homes, regardless of whether they had a family or not. We see very few people in nursing homes with a spinal cord injury. It's only when if you cannot be at home and have the medical and social support that would enable you to stay at home. The reason is that we've had that system in place, and we sort of try to follow that. The second thing is that nursing homes are quite few. So, and this is also something being debated now, whether we should have more nursing homes, because it might be better for some people, instead of living at home, than to actually be in a place where you could meet with other people. But yes, it's very clear that the support you get from your social environment has a major role. We've seen that throughout a number of conditions, a number of disabilities. And in response to the previous question, which is the most important thing, the social and or the physical activity, I believe that people rate a very high life satisfaction if their social support from the social environment is sufficient to their needs. So, and this is something we're facing the challenge of how to deal with this over the next couple of decades, where we see more and more people growing older and more people with a disability growing older. And the same happens all around the world.
Thank you. There's a webcast question.
You could be next. The question is, have you looked at spasticity reduction for people who exercise more? And if yes, what did they do to help this condition?
Good question. Short answer is no. We haven't specifically looked at that ourselves. But there is, studies that have done that in the past. And there seems to be some relationship. We see that in other conditions, for example, stroke. People who do strength training after a stroke have actually reduced their spasticity, so it may play a role. But spasticity is a very complex phenomenon, and clearly more studies are needed to define the role of physical activity here.
One more quick one just came in, I'm sorry. Were there any correlations between the amount of financial resources spent and the amount of LTPA among the subjects?
I'm trying to remember to what extent we actually looked at that. We did a number, no, I can't recall any association between sort of financial resources, but on the other hand, I'm not entirely sure that we actually studied that in detail, because it's not a very easy thing to assess. You can assess a person's satisfaction with their finances and whether that was related. So we have the data, but we haven't looked at it.
There's another question over here.
Hi, thank you for coming. So interesting. I don't think you mentioned anything about bone density.
No.
And how, and if low bone density, how bad is it? How dangerous is it? And what, don't tell me anything bad, but hint around.
There is a wealth of information out on bone density and how that can sort of be related to falls, related to fractures and so on. No, we did not look into that. That is a little bit part of the upcoming study where we're going to look into cardiovascular and autonomic nervous system. But we haven't specifically looked at bone density.
All right, do we have any other questions in the room or on the webcast? Is there anything else that occurs to you that you'd like to say out of the questions and the group that's inquiring as their concerns and considerations?
The only thing is that the questions are very similar to what we get back home. This is an area where, you know, it relates to, it's something that you can relate to when you grow older. And there are a number of factors that, this is a really complex interaction between so many factors. So we don't really know all of it, but it's interesting to see that the questions I get today are very similar to what I get from consumers back home. Okay.
Did you collect any data on cause of death of people with spinal cord injuries?
The question was whether we actually look into to death. No, we did not. We will, however, when we do the follow-up on those 123, look into that, because we were interested in people living with a spinal cord injury. However, we will look into those who that could not make it into this 6-year follow-up and see the reason why they opted out, or whether they have actually died, and the reason for that, and related somehow to age. It's in the periphery of the thing that you work on as a physical medicine and rehabilitation medicine specialist. You would like to make life livable for people, and but it's interesting to know a little bit more about what happens across the age of those 123 that we studied. So we'll look into that, but I have no data on it.
We have no? Anything else? We've got a few more minutes before we close up. She's coming right over.
I'm just wondering if some of the information that you had in this lecture tonight is available online, or because some of it went by pretty fast, or if you have it printed out or something.
And is any of this information available online?
I think yes, but the answer is yes, it's online. I'm not entirely sure how you access it, but yes.
Is, and we can answer how you can access it.
It is available online, and in our web chat, we've also been sending out some references and some resources for folks.
Oh, if you're not on the web chat,
But
where would we look?
But the recording will be available.
Oh, the recording, yeah.
The recording will be available
In about
on SPIRSIC.org.
in about a month-ish. Okay, but we will send out
The slides are also available today. If you stop up front, you can get a copy of the slides.
Slides are up
Yep,
front.
the slide printout.
Okay. Thank you very much, Dr. Lexell. It's
Thank you very
excellent to
much.
have you.